ただいまより基調講演、高齢社会における医療ニーズに応えるビッグデータの価値を開始いたします。座長は京都大学医学研究科社会健康医学系専攻長福原俊一先生です。それでは福原先生、よろしくお願いいたします。
はい、皆様お話は尽きないと思いますが、次のセッションを始めたいと思います。よろしいでしょうか。キーノートスピーチ、ミシガン大学の Institute for Healthcare Policy and Innovation の所長でいらっしゃり、またミシガン大学のスクール・オブ・パブリック・ヘルスの教授でいらっしゃいますジョン・アヤニアン先生をご紹介いたします。ジョン・アヤニアン教授は実は私の、ハーバード時代のクラスメイトでございます。彼はもともと総合内科医、先ほどのプライマリーケアセッションの同じアイデンティティをシェアしている仲間であります。同時にハーバードメディカルスクールとハーバードスクールオブパブリックヘルスがジョイントプログラムとして行っていたクリニカル・エフェクティブネス・プログラムという非常に集中的な臨床研究のトレーニングプログラムで30人の学生の中に私も混じってアヤニアン先生と一緒に勉強したことが非常に懐かしく思っております。その後アヤニアン先生はハーバードメディカルスクールDepartment of Healthcare Policy 医療政策学部講座で研究者としてキャリアを積まれ、これまでニューイングランド・ジャーナル・オブ・メディスンをはじめさまざまな一流誌に260編の原著論文を出版されております。でその後ハーバード医科大学の教授を長年された後、最近になってこのミシガン大学に作られました非常に巨大な医療政策、そしてイノベーションを領域とする巨大な研究所の所長として異動されました。ここには400人の研究者、そして医学部以外の12の部局の研究者が参加してさまざまなトランスディシプリナリーなリサーチを展開していらっしゃいます。アヤニアン先生は特にビッグデータを使ったそしてそれが臨床の現場、そして医療政策に還元されるさまざまな意味のある研究を発信されております。今日はそのビッグデータの価値、それがヘルスケアニーズとエイジングソサエティにおける高齢社会における医療のニーズにどのように応える研究ができるか、その価値についてお話ししていただきます。Okay, John, go ahead.
Thank you, Professor Fukuhara and the Organizing Committee for the World Health Summit Regional Meeting. I very much appreciate the honor of speaking to you today. My topic is the value of big data to meet the healthcare needs of aging societies, and I think an ongoing theme through all of our presentations today and all of our discussions is the importance of data to make informed decisions about how we organize our healthcare systems, how we pay for healthcare, how we deliver healthcare, and how we measure the outcomes of health in our populations. And so data is essential to the endeavors that we're pursuing in our countries and in our collaborations across countries. In my presentation today, I'd like to describe three major uses of big data to assess healthcare and health outcomes. The use of administrative data from healthcare systems, oftentimes data that are used to pay medical bills on the part of governments or private insurers. Secondly, to talk about clinical registries and cohorts that are established in different countries to help understand the outcomes and needs of some patients with major conditions. And third, the role of national surveys with examples from the US and from Japan about how nationally funded surveys can help to inform health policy decisions. I'll talk about the strengths and limitations of big data in healthcare, provide some examples of how big data are being used to assess healthcare in the US and Japan, talk about the government and university roles in developing big data resources and applying them in healthcare research and evaluation of health policies. And finally, talk about some of the practical challenges and emerging opportunities for big data in our respective countries. So what's the value of big data relative to some of the smaller clinical studies that we could do at our individual hospitals and medical centers? Well, they give us a much broader study population to work with that's representative of community health and clinical practices, not just in academic health centers, but in the broader delivery of healthcare across our countries. It also reduces the risk of selection bias that we sometimes find when we study the outcomes of patients in one hospital or just a few hospitals. It gives us strength in numbers, so we have much greater statistical power to conduct analyses. We can do subgroup analyses to look for confounding and interactions in our populations. And we can often use big data to confirm the observations from smaller clinical studies and generate hypotheses to focus primary data collection when we need more depth than we can find in some of the big data resources that we have. And another key question is, are the key variables that we use in big data audited, and are they accurate for the purposes for which we're using them? And that's a very important consideration when we're working with large data resources. So first I'll talk about administrative data, which are relatively inexpensive to obtain. They're typically created for healthcare billing or government monitoring of healthcare, the provision of healthcare in our countries. But one of the challenges is they have limited clinical information. So typically administrative healthcare big data includes diagnoses from ICD-9 or ICD-10, the International Classification of Diseases, procedures, and sometimes prescription drug codes for the medications that our patients are receiving. There can often be questions about the clinical meaning, accuracy, and completeness of these clinical codes in administrative data because they're developed not for clinical research primarily, but for paying for healthcare and monitoring the use of healthcare services. The types of administrative data we work with often include an encrypted patient identifier, and one of the challenges that I'll come back to later in my talk is that our ability to link different databases relies on a consistent patient identifier that can be shared between different databases. Many of these databases have provider identifiers of, for example, the attending physician or the operating surgeon for a hospital record. It includes patient demographics such as age, sex, or in the United States, race and ethnicity, where that's an important consideration when we look at healthcare disparities and equity between different racial and ethnic subgroups. It will often, for hospital records, include the dates of a hospital stay, or for office visits, the date of an office visit. And then, as I mentioned, the diagnosis codes, procedure codes, and disposition of the patient, where they discharge to home, to a continuing care facility, or do they die in the hospital. And then finally, because they're used for billing purposes, administrative data typically have very good cost information if we're interested from an economic standpoint in understanding where our healthcare resources are being spent. So here are a couple examples of administrative big data in the United States. One is collected by a federal agency known as the Agency for Healthcare Research and Quality, or HRQ, and it's described at the website here at the top of the slide in the Healthcare Cost and Utilization Project. And a second source of big data in the US is data from our Medicare program, which provides fee-for-service claims data for the elderly and disabled population in the United States. And our federal Medicare program funds a Medicare Research Data Assistance Center known as ResDAC at the University of Minnesota to work with researchers across the country who wish to use these administrative data for their own research. So our Healthcare Cost and Utilization Project, or HCUP, is actually a collection or a family of administrative databases maintained by the Agency for Healthcare Research and Quality. It includes our national inpatient sample, which I'll talk about in a moment in a little more depth. It includes a specialized pediatric hospital database known as the Kids Inpatient Database, or KID. It includes state inpatient databases from several dozen states in the United States, which include hospital records of all patients admitted to the hospital in those states, as well as ambulatory surgery databases, emergency department databases, and a nationwide emergency department sample that's drawn from those state emergency department databases. This is a resource that investigators anywhere in the world can use. There's a website shown here where you can request data and get online training to work with these data, and with a fairly simple process. So I'll talk in a little more detail about the U.S. National Inpatient Sample, or NIS, which is a national stratified sample of hospital admissions. It's the largest inpatient database in the U.S. that includes both elderly and non-elderly patients. Over 7 million discharges per year from 4,300 hospitals in 47 of our 50 states were included in this database in 2012, and it covers about 95% of the U.S. population and the hospital care that they receive. And the database actually goes back to 1988, so it's a good resource for doing longitudinal studies of hospital care and hospital outcomes over a 24-year period now. And from anywhere in the world, you can request access to study these data at a cost of just $350 per year for a faculty-level investigator and $50 a year for a student wishing to work with the data. And the web address shown at the bottom of this slide is where you can request the data and learn more about the data elements and the procedures for obtaining it. So this is a database that's nationally representative. It includes all patients and all conditions requiring hospital care, and includes in-hospital mortality and hospital charges. But two of the limitations are that there's no longitudinal data beyond hospitalization or an emergency visit, and it's often difficult to distinguish complications that occur after someone's admitted to the hospital from the underlying conditions that caused them to be admitted. Here are some examples of clinical studies that have been conducted by relatively junior investigators working with the National Inpatient Sample, looking at cardiovascular procedure mortality, looking at the introduction of endovascular aneurysm repair in vascular surgery, and changes in the mortality rate with that technical innovation in surgical care. And then finally, looking at some of the prevalence and costs and complications of new procedures in spinal surgery, a study published several years ago in JAMA. So really a wide-ranging resource to study both medical and surgical care in U.S. hospitals. The second major database that I mentioned are the U.S. Medicare claims data. This is a nationally representative and inclusive sample for all of our elderly patients in the United States, as well as those with chronic disabilities and end-stage renal disease, or ESRD. This is a comprehensive database, so unlike the National Inpatient Sample that only includes hospitalizations, Medicare claims include our outpatient records, rehabilitation services, hospice care, home care, and pharmacy claims. So a much more complete picture of the medical care that our patients receive through the Medicare program in the U.S. Another important strength relative to the National Inpatient Sample that's just a cross-sectional sample of hospitalizations. The Medicare claims data give us a continuous enrollment and complete vital status data. So once a patient becomes enrolled in Medicare, they remain in that U.S. federal insurance program for the rest of their life, and we can track their survival and mortality. And we can link all these different types of data longitudinally over time. But some of the limitations of this database are that it lacks utilization data for managed care enrollees in the United States, which is now about 30% of the Medicare program in the U.S., and it's limited to the 70% of our elderly and disabled beneficiaries who have fee-for-service care in the Medicare program. And like the National Inpatient Sample, the only clinical data that we have in this administrative database are diagnosis and procedure codes. Now, I want to also provide an example of a major Japanese database that's similar to our National Inpatient Sample, which is called the Diagnosis Procedure Combination, or DPC Database. This was launched in 2002 by the Japanese Ministry of Health, Labor, and Welfare, and linked to the lump sum payments that hospitals receive in Japan. This is a database in which university teaching hospitals are required to participate, and 82 of them do, and 872 community hospitals have joined voluntarily. It includes administrative data such as the patient's age, diagnoses, and complications. And one advantage over the U.S. National Inpatient Sample is it also includes some more detailed clinical data such as body mass index, tumor stage for cancer patients, stroke severity for patients with strokes, and the Rankin Disability Scale. And so in 2010, this included over 3 million discharges in Japan, which was nearly half of all discharges in the country. So here are two examples of studies actually that I've collaborated with colleagues in Japan, Professor Hashimoto, who's here today from Tokyo University, Professor Yasunaga, and Yusuke Tsugawa, a graduate student at Harvard, a physician trained in Japan who came to Harvard to learn advanced research methods in health policy. In the first of these studies, we compared the outcomes of laparoscopic or open distal gastrectomy for patients with early-stage gastric cancer, one of the most common causes of cancer in Japan. Using advanced statistical methods with propensity score matching, we actually found that high-volume hospitals had fewer post-operative complications than low-volume hospitals in Japan, suggesting that regionalization of care is an important way to improve outcomes. We also conducted a study looking at stroke outcomes and the association of hospital volume medical care for stroke with mortality and costs of care in Japan. And in this study, we found lower in-hospital mortality but higher costs for patients with subarachnoid hemorrhage in the higher volume hospitals. So suggesting there's an improvement in outcomes, but with some increased cost for stroke patients in high volume hospitals in Japan. And this slide shows a scatter plot both of mortality outcomes by hospitals, with mortality shown on the left on the y-axis and the number of stroke cases per 6 months on the x-axis. And as you can see, there's a fairly steep improvement in outcome, a reduction in mortality for hospitals once they get above 50 cases over a 6-month period, and then a gradual improvement across the span of higher volume hospitals. And the corollary of that is on the right-hand side of the slide, you see the total cost per case increase fairly steeply from the very lowest hospitals to volume hospitals to the medium volume hospitals, and then increase more gradually across the spectrum of higher volume. So the second type of data that I'd like to talk about in terms of big data resources are clinical registry and cohort databases. And here I have examples for both cancer and cardiovascular disease, which in the United States and in many developed countries are the most common causes of mortality in the population. The National Cancer Institute, part of our National Institutes of Health, sponsors the SEER cancer registries, and the National Heart, Lung, and Blood Institute, also part of the National Institutes of Health, sponsors a number of cardiovascular cohort databases. So our U.S. Surveillance, Epidemiology, and Results, or SEER program, was initiated by the National Cancer Institute back in 1973, and it's been expanded twice over the past 40 years in 1992 and 2001. It now includes 15 population-based tumor registries that cover about 27% of the U.S. population. And within those regions where the registries are operating, it captures almost 100%, about 99% of all cancers in those regions. And the regions were actually selected and funded to provide racial and ethnic diversity across sites in the United States. And those of you who are interested in learning more about these databases, which can also be downloaded by investigators anywhere in the world, can turn to the website seer.cancer.gov. This map of the United States shows the regions in which we have SEER registries, a predominance of registries on the West Coast, with the state of California fully participating in the SEER registry program, and other states in the Southwest as well. But we also have Midwestern states like Iowa, southern states such as Louisiana and Georgia, and northeastern states such as New Jersey and Connecticut. So within the SEER cancer registry data, we have demographic information, age, race, ethnicity, marital status, birthplace, whether someone was born in the United States or a foreign country, and their county of residence. We have information about the type of cancer, where it was located, for example, if it was breast cancer or kidney cancer, which side of the body it was on, and the date of diagnosis and how it was confirmed, particularly whether there was pathologic confirmation of the diagnosis, which is an important distinction between clinical registries and cohorts relative to administrative data, where we oftentimes don't have detailed clinical confirmation of the diagnosis in administrative data or claims data. Within clinical cohorts and registries, one of the most important features is the confirmation of the cancer or cardiovascular or renal or other diagnosis. There's detailed information about the tumor itself, the stage, the histology, the size, and positive lymph nodes, as well as the initial treatment, whether patients receive surgery, radiation, chemotherapy, or hormonal therapy up to 12 months after diagnosis. and very detailed follow-up data, active follow-up by linking to mortality records and other state and federal governmental records to understand whether patients are still alive after they've been diagnosed with cancer, and if they've died, what their cause of death was, particularly was it a cancer death or did they die from unrelated causes regarding their cancer. So here's an example of a couple studies conducted by some of the junior faculty that I worked with at Harvard before moving to the University of Michigan. Actually, a study looking at gastric cancer outcomes in the U.S., comparing U.S.-born and foreign-born Asian Americans and Pacific Islanders in the U.S. and their cancer outcomes. And then another study looking at more detailed care of breast cancer and whether radiation treatment was being provided in compliance with guidelines in the United States. In the field of cardiovascular disease, we have a number of databases sponsored by the National Heart, Lung, and Blood Institute. The website shown at the top of this slide describes much more detailed information about all the databases that are available. Once a database has been funded by this federal agency, after a period of time, it becomes available to outside investigators to apply for conducting research with it. We have a series of cohort studies here, one known as the Atherosclerosis Risk in Communities, or ARIC study, enrolled middle-aged adults back in the late 1980s and then followed them through the mid-2000s up to 2005 to understand what, in a community-based cohort, what some of the predictors of cardiovascular disease were, analogous to the precursor study that we heard about from Professor Clegg this morning at the opening session, taking a population and following it over time to understand what the risk factors and antecedents are of cardiovascular disease in a broad population. Probably one of the most famous U.S. cardiovascular cohorts is the Framingham Heart Study, which has enrolled over 15,000 participants in multiple cohorts since 1948, and in many ways defined the whole concept of cardiovascular risk factors in a way that we use it quite commonly now in epidemiologic and clinical research. And then finally, one of our newer studies is the multi-ethnic study of atherosclerosis, or MESA study, which has enrolled over 6,000 middle-aged and elderly adults in 2000 and has continued following them for the development of cardiovascular disease in a diverse multi-ethnic cohort. So the third and final type of data that I'd like to talk about today are the U.S. national survey databases, as well as an example from Japan that I'd like to share. National survey data oftentimes are very useful for health policy studies because they have rigorous methods in terms of their sampling of the population and their instrument design. For federally funded surveys in the U.S., there's a thorough documentation of the methods, often on the survey website, that provides clear guidance for investigators who want to work with the survey data. There are nationally representative samples and defined sampling weights, so an elaborate procedure in place to make sure that the findings from these national surveys are nationally representative. And then finally, in the case of many of these U.S. federal surveys, the data are readily available over the internet at no cost and often come with statistical programs to help new researchers begin to work with the data in SAS or STATA or SPSS, some of the major software programs that we use in the U.S. So I'd like to focus on one major national health survey in the United States, the National Health and Nutrition Examination Survey, or NHANES, which is a federally funded survey by our Centers for Disease Control. And it's used to monitor trends of selected diseases and risk factors, including the prevalence of different conditions, the awareness of people who have them. Oftentimes, for example, conditions such as hypertension or diabetes may be asymptomatic, and individuals may not even know that they have those conditions until they participate in a survey like this, as well as tracking their treatment and levels of control. So this is a nationally representative survey sample that dates from 1971 and now includes about 10,000 people who were surveyed in each 2-year period, with about 95% of those surveyed individuals actually undergoing detailed physical exams and laboratory assessments, and the population includes all ages from age 2 months and above. It has a response rate of nearly 80% overall, a little bit higher for children and a little bit lower for adults. And the health tests are conducted in mobile examination centers where patients have their vital signs checked in a standardized manner and blood tests, EKGs, other tests are collected. And it's a great longitudinal source of health outcomes because mortality data are linked in from our National Death Index. And in fact, more recently, genetic samples have been collected and are beginning to become available for larger cohort studies. So this is an example of the mobile examination center that travels around the country, different regions of the U.S., to take participants who've been surveyed and invite them in for physical exams and lab testing. And once those participants arrive, they undergo detailed testing of their hearing, of their balance, their body composition, different measures, for example, height and weight and head circumference for children. Their cardiovascular fitness is assessed. They undergo a complete skin exam, as well as tests for lower extremity vascular disease or neuropathy, tests of their muscular strength, their oral health. The physician actually measures their blood pressure and pulse and counsels them for sexually transmitted disease and HIV tests before they undergo those tests in a standardized fashion, and vision testing as well. And then this is a selection of some of the laboratory tests that participants undergo. So tests such as fasting glucose or glycohemoglobin levels to assess for diabetes, lipid testing, chemistry tests of renal function, electrolytes, and liver function, hematology tests looking at complete blood counts as well as different vitamin and iron levels, different types of hormonal tests such as thyroid hormone or other hormones that are measured in the population, tests for sexually transmitted diseases, I mentioned, assessments of tobacco use, and environmental exposures as well, such as lead and heavy metals and pesticides. So a very rich resource of clinical data in a nationally representative population-based survey. And these are some examples from junior investigators who've used this database for some of their early research studies, looking at some basic epidemiologic associations, such as red blood cell distribution width on a complete blood count and how that relates to mortality in a community-based cohort, or assessment of more of a social policy issue, which is the prevalence and access to care for chronic disease for uninsured adults in the U.S. So I'd like to give an example, one from the US and one from Japan, about how these nationally representative surveys can be used to understand major health policy issues. So in the US, since the early 1990s, we've been grappling with the issue of large proportions of our population, about 48 million out of 300 million in the United States, who were lacking health insurance as of 2010. And so the question was, does this have a meaningful impact, this lack of health insurance, on people's health? And does gaining health insurance have any effect in improving their health? So how can national survey data help policymakers to answer this question? So we used another nationally representative survey, actually one that's conducted out of the University of Michigan, known as the Health and Retirement Study. And this is a nationally representative cohort where adults in their early 50s are enrolled in the study from across the country, with oversampling of African Americans and Mexican Americans to have more ethnic diversity within the population. And then those individuals are followed every 2 years with surveys to assess their changes in health and their financial status and their use of health services, as well as various biomarker measurements. And they're followed into their 60s and 70s and 80s now, going back to 1992. So over 20 years, this cohort's been followed every 2 years. So several years ago, we used this database to look at adults who were insured before age 65, shown in the blue line here, to those who were uninsured, did not have health insurance, typically provided either through private insurance for people who were working or through the Medicaid program for those with very low incomes. But there's a large segment of the U.S. population, typically the lower middle income population, that before age 65 has had great difficulty getting insurance. And what we see are, in these graphs, are the declines in health from age 55 on. In the blue line shown for those with continuous insurance before and after 65, and the dashed line showing when people become eligible for Medicare, which all U.S. residents are eligible for if they've worked at least 10 years in the country. What we see is before age 55, those without insurance, their health is declining more rapidly. That's the group in the yellow line, the solid yellow line. And so by age 65, the difference in self-reported health outcomes and health measures between the uninsured and the insured has grown by an order of 2.5 or 3-fold greater difference. And once those uninsured adults become eligible for Medicare coverage at age 65, we actually see an inflection. What we would have expected is the dashed yellow line, a continued decline in health. And what we see is they see an almost immediate improvement within 2 years in their health outcomes. And so by age 72, at the end of this time course, the difference in health outcomes between those without insurance before age 65 and with insurance before 65 is actually about half as great as it would have been if those adults had remained without insurance. So, and a very important demonstration with a quasi-experimental study of how health insurance matters for adults as they age through middle age and into their elderly years. And in fact, in a closer look at this population, almost all of the benefit of insurance coverage is concentrated in adults with chronic conditions, in particular cardiovascular disease, hypertension, and diabetes. Along with the theme of this conference, some of the conditions that rise most prominently with aging in different societies across the world, and also where we have some of the most effective therapies through primary care. So we know that we can address risk factors such as elevated blood pressure or elevated glucose or cholesterol if patients are getting good primary care. And in fact, if they develop complications of heart disease or diabetes, we can improve their quality of life and length of life with good specialty care. So an important demonstration of how insurance is linked to access to care and better health outcomes. And so, for example, our study, which we conducted with the Health and Retirement Study, was addressed in a New York Times editorial before we had the Affordable Care Act in the United States, and making the case that without insurance, we saw much worse health outcomes in our middle-aged and elderly population. It led to a report from our U.S. Institute of Medicine, which looked at the complete set of studies that have been conducted on this topic, including 15 quasi-experimental studies through 2009, and found that there was convincing research that lacking or gaining health insurance had on health outcomes, and that this was a compelling case for action to achieve immediate insurance coverage in the U.S. And so within a year after that, with the election of President Obama and the support of Congress, the President signed the Affordable Care Act in 2010. And since 2010 through 2015, we've now seen 16 million more adults in the United States covered by Medicaid or private insurance through health insurance exchanges. And now we're in the process of studying what impact that this improvement in health insurance is having on health services and costs and outcomes. So I'd like to also share an example from Japan of the use of a national survey to understand health outcomes in elderly patients. And this is the comprehensive survey of people's living conditions. It's a nationally representative cross-sectional survey of Japanese households in all 47 prefectures. It measures health spending as well as self-reported mental and physical health outcomes. And here I would highlight a study led by Akihiro Nishi, who came to Harvard from Japan as a research fellow, worked with Professor McWilliams and Professor Kawachi, who we'll hear from tomorrow, as well as Professor Hashimoto and colleagues here in Japan, looking at the health benefits of reducing patient cost sharing for elderly patients in Japan. And this was published in the Bulletin of the World Health Organization of 2012. So here we see what happened to cost sharing and out-of-pocket medical spending in patients over age 70. In the solid line, what that shows are lower income elderly adults who are subject to reduced cost sharing at age 70. Without that reduced cost sharing, you would see that their cost sharing would continue to rise after age 70, but there was a steep decline right at the time of that economic benefit in terms of their insurance coverage. And higher income adults, shown with the dashed line, really did not have a significant change because they were not eligible for the reduction in cost sharing at age 70. And I think what was very important from this finding was the link between economic well-being and mental health well-being in elderly patients. And we've seen similar effects in the United States, for example, with the expansion of Medicaid coverage for low-income adults being associated with both reduced financial stress as well as improved mental health outcomes in the state of Oregon. And here what we see in the y-axis are the self-reported mental health scores, which were declining in those low-income elderly adults before age 70, and a fairly rapid and significant increase in their mental health outcomes right around age 70 with the reduced cost sharing. So here, another example of a quasi-experimental study conducted with a national survey data resource like the one that we did in the US, this survey in Japan, to draw important conclusions about health outcomes as people age in society. So what are some of the practical challenges of working with big data? So as I mentioned earlier in my presentation, the accuracy of administrative data is often unclear, and we have to do as well as we can to try and validate the diagnoses and procedures that we find in those databases. And there are ways to do that, for example, by looking more closely at medical records within specific health centers or hospitals to understand whether the diagnoses that we see in administrative data are actually confirmed in medical records. And the clinical information, as I mentioned, is fairly limited, so administrative data may tell you whether a lab test was ordered. It won't usually tell you what the result of that test was, and that's an important limitation for faculty and trainees who want to conduct more clinically oriented research. I think another important opportunity and challenge is the ability to link different large databases, and those data linkages require shared identifiers. In the United States, we have Social Security numbers, which are often used to link big databases. Without shared identifiers, we can sometimes do probabilistic linkages based on people's date of birth or age or gender, but those are more challenging. So ideally, the government agencies collecting big data are applying consistent identifiers that can be used for those linkages. And then finally, these studies often require an experienced statistician to help with the data analysis, especially for some of the complex national surveys that have sampling weights that need to be used appropriately to generate accurate results. So I'd like to close just by talking about the role of both governments as well as universities in the quest to use big data most effectively. So governments have a very important role to play because they have the legal authority to collect data, and they can mandate reporting of hospitals or medical groups or public health authorities. They also have the budgetary resource to support data for policy and for research. And so throughout this conference, we're seeing many examples of big data being used to frame issues around aging or communicable diseases or non-communicable diseases. Most of those data come from government-funded data resources that can be pooled within countries and then compared across countries to draw important conclusions about how different health systems are performing. Governments also have an important role in terms of funding the statistical and methodologic expertise to oversee the sampling plans for these big databases, whether they're clinical registries and cohorts or national survey data. They help to fund the data acquisition and the data management. And then, very importantly, the data security and privacy is of utmost importance, because if we want to continue to have public support for government funding of big data resources, we have to ensure that confidentiality and privacy are protected and that the data are used for legitimate purposes, whether in research or health planning and policy evaluations. And then finally, governments can help with data distribution to make sure that the widest network of investigators in the public and private sectors and within university communities can work with the data. And then on the other side, universities have a very important role to play in advising governments on how databases should be designed and what some of their applications and uses can be. Also, universities often are the source of a wide-ranging expertise in clinical medicine, in health economics, and public health research methods, such as statistics and epidemiology, which are very important for getting the most informative insights from the databases that are funded with government resources. And then university investigators can conduct analyses to improve health policy and health care in collaboration with government agencies that fund the delivery of health care, the collection of health data, as well as private sector healthcare organizations and peer-reviewed journals that publish the results of our work. And I want to close just by highlighting some of the emerging opportunities in big data. So most of the data I've talked about today are forms of data that have been around for decades, such as administrative data and clinical cohorts and registries and survey databases. But we now, in many countries, are developing electronic health records. And these have much more detailed clinical data on the procedures and medications and test results that our patients undergo. And many of those databases are beginning to include genomic and proteomic and metabolomic data as we move to an era of personalized medicine and precision medicine. Bringing those newer forms of biologic data into the research that we do, whether it's for clinical research or health policy and public health, will be an important opportunity in the future. As some of the presentations over the course of the day have highlighted, we also need to understand not just clinical data, but social and environmental health measures. The slide that Professor Clagg showed of the different communities within the city of Baltimore and their differences in health outcomes and survival are very much driven by the social and environmental influences in those communities where people live. And so we need to think not just about the healthcare system, but the broader social and environmental issues that influence health. And understand the neighborhood and community effects that those social and environmental factors determine. And then finally, as much as possible, we need to be moving to longitudinal and social network data to look at health outcomes over the life course and understand a network perspective on health outcomes, as we see in some studies from the US, conditions such as obesity and smoking are propagated through social networks in the population. And so understanding not just individual health outcomes, but the outcomes of networks of individuals will be very important. So I thank you for your attention, and if time permits, I would welcome questions.
Thank you very much, John, for excellent presentation. あと5分40秒ありますので、日本でもいよいよビッグデータという言葉が、叫ばれるようになり、厚労省も他の省庁もビッグデータとヘルスを結びつけたさまざまな研究助成、そして各大学や研究者がいろいろなビッグデータアナリシスを日本でも開始しているところであります。いかがでしょうか。この良い機会ですので、マイクはありますか。手を挙げていただいて、どんどん質問していただきたいと。はい。マイクラグ。Yes.
So, John, don't need that. Yes. That was a tour de force, and it was wonderful to see this sort of encyclopedic view of the resources available. So, I was trained as an epidemiologist, and you were trained as a health services researcher. So, let me ask you a question and see where you come down on this. I've had friends, colleagues who feel that we don't need to do clinical trials anymore because using the advanced techniques that you talked about, propensity matching and others, that we can infer from observational studies of large data sets the value of therapy. I'd like to have your thoughts on that.
Sure. I view clinical trials as very much complementary to the health services research and epidemiologic studies that can be conducted with big data. Oftentimes, we hold clinical trials up as the gold standard of evidence, and they're very strong for understanding the average effects of a therapeutic intervention and eliminating the effects of confounding, because they balance both measured or observed factors as well as unobserved factors. But they don't often tell us in great detail about marginal effects and heterogeneity, how different subgroups within the population may respond to different therapies. Oftentimes they have significant exclusion criteria. For example, in the US, as we think about a super aging society in many countries, very elderly patients oftentimes are excluded from clinical trials. So I think we continue to need observational studies and epidemiologic health services research studies to understand populations such as the very old who may be excluded from studies, as well as to get larger numbers for subgroup analyses. So I think that it's not an either-or question, but really an opportunity to fund both. And also an important role for observational studies is, once we've done a clinical trial, is tracking whether the outcomes in real life. So even if a high-quality academic health center can achieve certain outcomes in a clinical trial, do we see those same outcomes when a new treatment or a new procedure is implemented in a broader cross-section of community hospitals, for example?
他に、はい、後ろの方で手が挙がりました。慶応大学の漆原先生、彼は京都大学の SPH の卒業生であります。
Thank you for your clear presentation about the database in the United States. Yeah. So I was studied under the direction of Professor Fukuhara. I'm a graduate of the Office of Laboratory of Professor Fukuhara. So I have a question about the ethics. So because you introduced many types of database for research, we know that you may have the legislation such as Health Insurance Portability and Accountability Act, Privacy Rule. However, it does not cover such, the databases just you introduced. How do you overcome the issue of the private information protection and also privacy rules?
Okay, so the question is, in the databases, the different types of databases that I presented, how do we address privacy and confidentiality protection? In the US, we have something called the Hipaa, or Health Insurance Portability and Accountability Act, which was implemented back in 2003, and initially really slowed down a lot of the research, particularly with clinical databases, because it required new forms of patient consent for us to work with those databases. Within a few years after 2003, though, I think our research system learned to adapt to those new requirements. And I think it's heightened our level of attention to data privacy and security, generally in a good way, even though it's created some administrative barriers, particularly to enrolling patients in clinical and population health research. I think one way that some large health systems in the United States are dealing with this is at the time when patients come in to begin medical care, they actually have them sign a consent form saying that their medical records can be used with privacy for healthcare research. And I think that not all health systems in the United States do that, but the ones that have implemented that practice get a very high rate of patient agreement to participate in, have their records be used for observational research, particularly, for example, cancer patients in some of our large cancer centers. And that's a way to make, for example, the new emerging data of electronic health record data much more available for research with patient consent. But it's a challenge that we're still addressing in the United States.
It is a kind of the comprehensive consent?
It is. In the health centers that have done this, it is a comprehensive consent that patients agree that all of their data in their electronic health record can be used for medical research.
Okay, thank you for your explanation.
はい、あと一人、この方です。はい、どうぞ。ちょっと時間がないので、こちらにこう。
日本語ですみません、
はい、
ナショナルデータベースを使うということはファンダーが、国ということになりますから、その国になんか望まない結果を出すことに対するなんかそのコンフリクト・オブ・インタレストというかそういった結果しか出ないことっていうのは、ないのかとそういうことに対してどういうふうにケアしているのか、一方で日本だとなかなか多分ちょっとこれはよく分かりませんけれども国からファンドされてしかも情報を提供されるとなかなかそういう国に不都合な結果を出しにくいっていうのが多分あると思うんですけれどもそういった問題をどういうふうに解決されているのかできればお願いします。
I think that's a very important consideration. The question is, how do you resolve conflicts if the data are funded by the government, but your conclusion may be contradictory to a government policy? And I think it's very important for the governments that fund large data to give their university researchers the protection and the freedom to publish objectively what they find. In the short term, sometimes it will not support a specific government policy, but ideally that helps the government to improve the policy. And for example, in the case of insurance coverage in the US or cost sharing for elderly patients in Japan, like the two examples I showed, I think in both cases it helps to inform government policy in a way that leads to more evidence-based policy decisions, and there will be a tension there. I think for the most part in the US, we've achieved that government acceptance of the objectivity of university researchers, but it's an ongoing tension, and I think it's an important question for university faculty and government or ministry officials to be in regular communication and to ensure that in the U.S. what we call academic freedom, that we have, whether we have funding from the government or the private sector, that we have the freedom to publish our results in peer-reviewed journals and at public meetings so that we can communicate freely about our scientific findings.
日本でもアカデミックフリーダムがあると信じておりますのでこれからそういうことがこれからいろいろなことが起きてくるんだと思います。大変もっといろいろ質問があると思うんですが時間になってしまいました。リセプションにも I coming to reception, right? So 皆さん拍手で Thank you very much.